Welcome to Focus on Health, a show on all matters health, wellness, and lifestyle. I am your host, Joy Bofenda, and on this episode, we discuss diabetic foot wounds and ulcers alongside Dr. Shilpa Mulki of the Lions Diabetes Care Center. But before then, take a look at the health updates. So, welcome, Daktari.
Thank you very much.
Kindly introduce yourself to our audience.
Okay, I'm Dr. Shilpa Ranjan Mulki. I'm a physician and I have done a degree in diabetology as well. I have very keen interest in diabetes-related foot and wound complications. So I'm part of the team here in Lions DCC. I'm part of the multidisciplinary team that manages foot and wound and diabetes.
Okay, so what exactly is diabetic foot wound or ulcer?
Okay, so diabetes-related complications are many. So they start from non-ulcerative, that means non-wounds, and they go into full-fledged wounds. So it could be as simple as what a layperson may call a corn, a hardness in the skin. It goes as far as that's the beginning stage of a wound. So it can range from that to abnormal curling up of the toes, up to full-fledged wounds that can be at specific pressure areas, or it can be in abnormal pressure areas, for example, in the midsection of the foot, where our feet are like this, and it becomes somewhat like that, where the midsection has a fall. Now, that's a different also type of wound. So diabetes-related wounds are more related to nerve-related issues and circulation issues, and then compounded or complicated by infection.
And why exactly do they happen in diabetic people specifically? Why not hypertensive, etc.?
Okay, so in a person living with diabetes, we don't call them diabetics anymore. Appropriations. But it's really important. A person living with diabetes should not call themselves diabetics because it's not what should take over their lives. Diabetes should be part of their lives and should not be ruling it. In a country, telephone lines are very important for communication. If there is an attack or an act of terrorism happening at point A, the only way the army can reach there and correct things is through communication. Similarly, in a person living with diabetes, due to high uncontrolled sugars, the nerves of the body, that are the telecommunication lines of the body, die. They die from the periphery or from the tip of the toe upwards. So when a person develops pain, have you ever stepped on a Lego?
Yes.
How painful is that?
Very.
So pain is a gift. Pain is something that must be there. When we step on the Lego, we retract, and it's a blessing to have pain. Those who have down communication lines that are not working do not step away from trauma. So they develop wounds, more common. So it's nerve-related complications. And then also, in persons who are living with diabetes, there is a blockage in the arteries that supply the feet. Just like how when you garden, and if you don't water your plants, will they thrive? They will not. So and similarly, if there is a wound or if there is a complication in the foot, and if the central part of the body or when the body is unable to go and send soldiers to heal the wound, it becomes a chronic wound. So there are acute wounds that are usually traumatic, or they're associated with burns. In the cold weather, we tend to expose our feet to GCOs via electrical heaters. We develop blisters. Persons living with diabetes develop blisters because the skin is frail. They don't notice, and that develops into a wound. So it can also range from hardness of the skin in certain areas to abnormal pressure areas developing wounds but it's complicated by nerve problems as well as circulation issues.
Okay, and what are the characteristics of these wounds? Are they smelly? Do they have margins, or are they just like any other wound?
They can be very specific. So they can be at specific pressure points. They usually don't have, I've been in the field for such a long time, I don't smell them anymore. But yes, certain wounds are smelly because of co-infection. And then the margins can be, they're usually not rolled up, they're not very specific. They can merge into, and they're irregular in margin. It depends on the nature of the wound, basically.
Okay.
It can be on the edges, you can find very hard skin, and then the middle of the wound may be clean. So it depends on what is predominant, what predominant pathology is in that particular wound.
Okay.
Yes.
So a person who has the initial stages of or pre-diabetes, are they at risk of getting these wounds?
Yes, they are.
Okay.
Yes, they are. These are the persons especially who don't take extreme care, as they should. The whole repetition of exposing your feet to the Chico, you develop blisters, or you wear the wrong shoes and you develop a blister. We have people coming in who don't know that they have pre-diabetes. They've developed a wound, it has become chronic. Chronic is when wounds don't heal within 6 weeks of having occurred.
Okay.
Yeah, they develop a trauma, or they've developed a blister, an infection, a shoe bite, so to speak, and it's become chronic, and then they diagnose themselves, and then they're diagnosed to have pre-diabetes.
Okay.
So it goes both ways, with diabetes as well as pre-diabetes.
Okay. So are there risk factors for getting these wounds in people living with diabetes?
Yes, of course. Persons living with diabetes with uncontrolled sugars, those who smoke in concurrent with their living with diabetes, those who have family history of wounds in the past, and those who have chronic kidney disease are more prone to wounds that tend to take a longer time to heal. Yes.
Okay, and you also mentioned that the locations where they happen. Could you tell us more about that also?
So I'm using footwear as an example of where the foot lesions can happen. If this is my foot, so first of all at the tips of my toes, and then over where the toes meet the foot, actually, so that's the metatarsal head. It's very common. There oftentimes when we get wounds over the top surface of the foot as well, and then there are times when we have bunions wherein the great toe goes inwards or goes outwards, inwards most of the time, and the bone sticks out, and that's where we get ulcers as well. And then we set the metatarsal junction, and then like I said, in the midfoot. So if we have to demonstrate this as the bottom part of the foot, in the midfoot, if it goes below the level of the contour of the foot, it's called a Charcot neuroarthropathy. And then the heels of the feet, especially in persons who are recumbent or who are lying down for a long time. This is usually in persons who are bedbound. Yeah, they develop pressure ulcers over the heel. Apart from that, it's not that a person living with diabetes doesn't have concurrent issues like venous insufficiency or varicose veins. So at that point in time, ulcers develop over the inner aspect or the outer aspect of the foot, of the leg as well, the lower 1/3 of the leg, and those are a little difficult to heal as well because of metabolic management. That means your blood sugar levels are not good enough, and or there is infection. Wounds can be managed with different ways. So yeah, those are the common areas.
How can an individual know that their wound is not healing? What are the timings of wound healing?
So ideally, an acute wound, something that's opened up today, should be able to heal within 3 weeks. If it is getting bigger, if the surrounding skin is becoming red, if there is an ooze or fluid coming out of the wound, it definitely needs to be checked. If a wound remains status quo for more than 6 weeks, it's what we call a chronic wound. Now, chronic wounds need recurrent reminding and poking, as I say, to heal. Like I said, if there's a constant problem at the border between two countries, it will be ongoing. It will be a chronic thing. There won't be any reinforcements sent. For reinforcements to be sent, there has to be something. There has to be some kind of irritation or instigation. So that's where wound management comes in. The most important thing in wound management is reminding the body and reminding the immune system and everything else that, hey, there's a wound here. It needs to be healed. Send reinforcements. So the most important thing, according to global standard of care, is sharp debridement. There are different ways that we can debride or clean out dirty tissue from wounds, but the most important and the most research-based effective method is sharp debridement. A simple, normal saline clean. Do not use betadine, don't use hydrogen peroxide. People need to move on from that. Please, people move on. But do not use hydrogen peroxide and betadine, that's concentrated betadine in wounds. Yes, some dirty wounds require a cleanse with betadine, but it should be diluted betadine. topic for another day. I can go on and on about it. But normal saline clean, sharp debridement, and a dressing dependent on how much the wound is weeping.
Okay.
There are different dressings that we can use. My team here, we don't consist of me alone. I have a wonderful team of wound care nurses. I call them magic fingers because it's not just the fingers that work and it's not the dressings that work. It's how they counsel the patient on how to take care of their wounds that makes a whole world of a difference. And that's why we call them multidisciplinary care. It's not a one-man job. And most of us are women, happily so. So sharp debridement, once you open the dressing, clean the wound with normal saline alone, sharp debridement, and then we pick the dressing. The dressing has to be able to maintain moisturization within the wound. The wound shouldn't be too wet within, shouldn't be too dry. And that's where all of us discuss as a team on how to manage this. Yeah. After the wound is dressed, depending on where the location is, offloading is extremely important. If I pinch you, Joy, here continuously, and you develop a wound, and if I continuously apply pressure there, will it heal? It will not heal. So it needs to be offloaded. If it's at the tip of the toe, we need to offload. And that's where footwear comes in and where orthosis comes in. So that's where we can put in measures. Right now we have simple ways of putting in measures like we roll up gauze. It's cost effective, but it's not the best. We do have better things coming into Lions DCC, the Foot and Wound Center, that we're able to it's cost effective and it will be permanent because once a wound happens in one area, it is very likely for it to recur. So offloading that area by all means in a long-term basis is extremely important.
We're taking a short commercial break, but before then, take a look at the Did You Know segment. Welcome back to Focus on Health. We are continuing the conversation on diabetic foot wounds and ulcers. Take a look. So, would you advise an individual to get their wounds dressed at home or care for it at home? And how can they do it?
Okay. I wouldn't encourage entirely for wound dressings to be done at home. However, in the future, what we are planning to do is we are planning to have nurses available that are specifically trained by us with standard of care measures in place to do the wound dressing. So there are many people who have joined our group and who are interested in being trained in the right way to do the dressing. The reason for why I don't encourage caretakers to do the dressings by themselves is one, sterility, the cleanliness of the area. A lot of the times when we give in for caretakers to do the wound dressings, the environment is not exactly the best. Flies end up coming and sitting, and then we have issues with maggots coming in with the wounds next time. Maggot therapy is amazing when it's coming from a sterile place like Calro. We work with Calro regularly to do maggot debridement therapy, so it's quite interesting, but that's sterile maggots. Now the ones that come from houseflies, those are butterfly maggots that we use from sterile therapy. Maggots from houseflies can be derogatory to a wound, and so we try to discourage. But if it's a clean wound and if they're in touch with us regularly, or if we're able to train a nurse to do it at their home and they're in regular touch with us, it helps.
Okay, and how best can they care for this dressing that have already been put in place by the doctor or the nurse?
Do not wet it. Most importantly, do not let any water enter, otherwise it macerates, just like when you stay in the swimming pool for too long and your skin becomes too soft. And so the wound may not be much affected, but the peri-wound skin or the skin near the wound, that breaks down and that can lead to a bigger wound. So that's why we don't encourage. But what we do is if there's a dressing underneath, we have rain boots. So I encourage my patients to buy the rain boots, and while they're taking their showers, they allow minimum water, if at all any water, to reach the wound dressing. So yes.
Okay, so no water. And what about, adding a little bit of salt and water and vinegar? People add vinegar to water and clean these wounds. Would you advise on that?
Wounds, would not advise a person to do it on their own as such. If it's an acute wound, if I'm a person living with diabetes and I develop an acute wound, for me to dress it for a couple of days with just salt water, which is not too hot, checked by someone else, because their nerves may be intact and I may not be able to sense heat of the warmth of the water, and I don't burn myself. So if you check for me and the water is good for you, and if I clean the wound with salt water, and if it's in the healing process until you're able to meet the doctor, it's okay. No vinegar. Vinegar is used in certain cases. Vinegar soaks are partially recommended in a few cases, but that's for now us as the MDT Foot team to take over and do.
Okay, and at what point when an individual gets an acute wound should they now seek a doctor? Or if it does start healing on its own, should they just stay at home?
Also wouldn't encourage that. Would like for a physician or a surgeon or a podiatrist or a foot health specialist to be able to take a look at the wound once. There are certain things that are called red flag signs for wounds. So if there is any ooze from the wound, for example, if I get injured today and if it's in healing process, if I see the skin is closing and there's no redness around, not much of ooze, it's okay. But within 3 to 4 days, 4 to 5 days, if I see now the skin around the wound is becoming hot, it is becoming red, it is becoming more painful, if at all the pain sensation is intact, yes, it must be seen, even within 1 or 2 days. If there is pus coming out of it, if there is it looking angry at you, basically, it's a good idea for it to be seen by a physician.
Okay, and considering most of these people are still working and they have to go back to normal function, are there ways that we can make this easier for them even when they have these wounds?
Yes, of course. Offloading devices help with quick healing. We do offer certain therapies over here which are not available outside. We are home growing some techniques which are proving to be very good. They are global standard of care with an adaptation of our own way of doing it because of cost. So yes, there are certain things that we can do to hasten wound healing. A good nutrition is very important. Persons living with diabetes-related foot ulcers do require slightly high carbohydrate and protein intake because you're building blocks, isn't it? And there's a little extra energy expended in going to healing that wound. But diabetes management, sugars management should be intact as well. Infection control, offloading, like I said. This is where our podiatrist comes in. Like I said, we're a multidisciplinary team. As a podiatrist, they come in, they help us with the offloading wherever they can. And yes, that's how you hasten wound healing.
Okay, I'm also seeing that you have a very nice collection of shoes.
Yes.
What are these for?
So what we have over here are footwear that's available for persons living with diabetes. This is something that we call, well, the importance of footwear for any individual is comfort and protection. Well, these are open. We are going to be getting closed shoes also very soon. The idea of having straps is adjustment. Everyone's different, right? Just because the shoe cannot fit everybody, and then those who have thicker dressings will be able to adjust the straps. And the importance of the heel counter is support from behind when they walk. Remember, the nerves also weaken muscles. Nerve damage weakens muscles, and so the normal heel to toe movement at the ankle joint is not adequate. So this supports the foot in entirety. So it doesn't have any abnormal pressure points. So the outer sole is very thick and it's very sturdy. You can feel it. And then the inner sole is what's important. It's called an MCR, or microcellular rubber inner sole. Yeah. So it should go in halfway and come back out. So it supports abnormal pressures in the feet wherever they are, and it doesn't allow for ulceration. There are times when we have to modify these shoes. For example, these are shoes now for people living with toe ulcers or ulcers at the junction of the toes and the feet. So the pressure comes onto this area, and so that the wounds in this area can take some time to heal. Right? So this is an anterior offloading. This is how we manage wounds. In a person living with a heel ulcer, of course with support, but they can use something like this where there's a deficiency in the posterior aspect or the back aspect of the foot. So the heel is offloaded to a certain extent, and the patient's wounds heal faster. Yeah. So a good mark of footwear, as per my colleague who's a podiatrist, always says that you must have the posterior support, a good outer sole, and a good insole. So this is what we call an insole. When a person does not want the footwear or does not have a wound that needs to be offloaded in as intensely as this, what we can do is we can provide an insole, cut it to their shoe size. Of course, this is size 8. It's very small for me, very big for me. So if there's a hardness in the skin in a certain area, we can put this inside their footwear and create a deficiency in the insole such that the hardness is does not have any pressure and does not continue to remain hard. It either remains that way or it softens up with the right management. And so insoles are another option for persons living with diabetes to prevent further ulceration in high-risk patients. Yeah. Do you want to talk about the bunnies, heel caps and stuff? Okay. Do you want to frame that? Yeah. Or do you want to? Okay. So sometimes, again, in persons living with diabetes, if there has been an ulcer in the metatarsal region, and the wound has healed, and they do not want to wear different footwear, which is acceptable, life has to go on, we can give them something like this. It's an orthosis, which is a silicone orthosis, which is to be slipped in like this, considering this is the great toe, and it'll be offloaded such that it doesn't have risk of ulcerating again. Yeah, because these areas are very sensitive, and there can be recurrence of wounds in such areas. Yeah.
So we also do have a lot of people undergoing amputations for the case of diabetic leg ulcers. What is the cause of that, or how do you arrive to that decision?
That's a very complex question. That is an individualized question. Unfortunately, there are a lot of needless amputations that happen here in all over the world, not just here. But I'd like to focus on Kenya. Lots of needless amputations because one may feel that instead of undergoing regular wound dressings, it may be better to just take off that appendage if it's a great toe or if it's midfoot. Wound management can be very complex, but also requires a lot of patience and also requires a bit of finances. So if an individual is just not affordable for sometimes chronic wound dressings, I think the inclination of the clinician is to go in and suggest an amputation, say, just be done with it. Okay. But the implication of an amputation, mostly major amputations, is 50% mortality within 5 years. That means within 5 years, 50% of these individuals die. If it is, especially if it's a needless amputation, it takes a toll on our statistics and on our working population. If wounds are picked up in an early stage and managed correctly in an early stage, most of these amputations can be prevented. But it does take a lot of training. It takes a lot of updates by clinicians to be able to understand that and to be able to follow global standards of wound care and management. Also takes a lot for non-surgical and possibly non-MD clinicians like GPs and MOs to be able to pick up smaller lesions very quickly and insist with the client or the patient to hurry to be seen by the right individual, by an MDT preferably. When an MDT takes a look at the wound, or a multidisciplinary team takes a look at the wound, when infection control, insulin management or diet management or diabetes management takes place correctly, and when sometimes revascularization happens. So like I said, sometimes the arteries are blocked. If we're able to find a way, finances being a big burden, if we're able to find a way to revascularize, these patients do very well. We are happy to say that we have prevented minimum 70 to 80 amputations within our center by healing wounds that were that have come in a chronic way and in on the verge of being amputated. It's about patience. It's about knowing how to go about it. And of course, it's the best thing to do would be to catch it early and treat it at an earlier stage with the right tools and in the right way.
Okay.
Yeah.
So you've emphasized a lot on the prevention aspect. How does regular foot examinations, especially by the person living with diabetes, how can it be done?
My usual thing to say is please take a look at your feet before you sleep. So, if a person is able to sit on a chair every day before they go to sleep, take a look at the undersurface of the foot, take a look at the upper surface of the foot, and look between the toes. If they find anything abnormal, they will pick it up. Wow, the most important abnormal things include change in the color of skin. We are not individuals who may be able to display redness of the skin. It's not possible. With our pigmentation, it's not always picked up. But any darkening of the skin in an area, any place where they feel that the skin is hardening, any open wound which you have observed, any whitish discharge or soft skin between the toes needs to be seen by a doctor immediately, and they need to be put on the right management. Even within the nails, the edges of the nails, if they find that there's any swelling, it's important to be picked up. Having said that, when you take a look at your feet every day, this is what my colleague says, you learn it like the back of your hand. You see, so if there's any abnormality, it gets picked up immediately and you bring it to us to be seen. And we hope to be able to reassure you and say, don't worry, all's fine. Or no, let's look into that.
Okay, that was such a lovely conversation, Dr. Kindly give us your parting shots in relation to diabetic foot and wounds.
Okay. Many wounds end up in needless amputation. I think on behalf of clinicians, it's important for us to understand that early lesions need to be picked up. Every time you see a person living with diabetes, please ask them to remove their socks and shoes and just take a quick look at their feet. There are risk stratifications that are available online for us to tell when you need to refer. And we are here to help you out with that. We have a hotline for it so that you can be included in our WhatsApp group, and we're happy to be able to help. I'm available on it and I respond very fast. So any wounds you see, any abnormalities you see, we can help out and guide you in the right direction. That's on behalf of clinicians. We need to update ourselves. For advice for persons living with diabetes, like I said, take a look at your feet before you sleep. Moisturize well. Vaseline is not a moisturizer. Use a good emollient.
Okay.
Oils do not provide moisture, they retain moisture. So ask your doctor for the appropriate emollient or an appropriate cream to use, which is non-fragranced. And then if you'd like still to put that one layer of Vaseline that makes you feel better at night, it's good. Avoid GCOs, electrical heaters. When it's cold, layer up rather than anything. And if you have the slightest doubt with anything, please don't hesitate to ask your doctor, or even as a patient, we will give you a number and you can display that and you can send us WhatsApp messages and we should be able to help you respond. Yeah?
Okay, thank you. Very informative conversation we've just had, and just as Dr. Shilpa has emphasized, diabetes can actually knock you off your feet, but before then it can be prevented and managed. I have been your host, Job Offender, and until next time, stay safe, stay healthy, and live with the Healthy You segment.